So our chief guest is Mrs. Srimati Shoba Koshy, ma'am, who is a former Chief Postmaster General and has been appointed Chairperson of Kerala State Commission of Protection of Child Rights. And as we know, October is a month of breast cancer awareness. We have been hosting different topics about breast cancer awareness campaign every day. And today the topic is about screening guidelines for high-risk women. And our panel of experts today are Dr. Sharon Abraham, who is Consultant Medical Oncologist, Anandapuri Hospitals and Research Institute, Jubilee Memorial Hospital. And the next, Dr. Deepa Rajmohan, who is Consultant Head and Head of Department of Radiology, Aster MIMS, Kannur. And Dr. P.G. Jayaprakash, Radiation Oncologist, Trivandrum, who will throw more light into the subject about the screening procedures and protocols being done on the high-risk women in our society. So I welcome everybody. Ma'am, few words, ma'am, Koshy, ma'am.
Hello, can you hear me?
Yeah.
Can you hear me? Okay. Shall I speak in Malayalam or English?
No, anything, whatever is fine. Everything is fine.
Okay, I can then speak in English. I would like to first of all record my sincere gratitude to the IRIA's Kerala chapter, the Malayalam Movie Artists Association, AMMA, and Swasthi Foundation for giving me this opportunity to be part of this month-long Pink Month celebrations for creating greater awareness about breast cancer. First of all, the question arises, why do we celebrate this event every year, this month-long awareness campaign? Why is it that WHO in 2021 decided to invite all countries to celebrate this global breast cancer awareness initiative every year? The answer is very simple. The answer is simply that it is to prevent or eliminate preventable deaths. And it is one of the goals of the Sustainable Development Goals of the United Nations also. Why do we categorize the deaths under breast cancer as preventable? So for that, we need to take a better look at the data and the status of this disease in different countries. Take, for example, the United States. There, the incidence of disease is much higher than in India. And yet, over 90% of the people are given prompt and effective treatment so that they can go back to their normal life. But let's take a look at the situation in India. The number of people who the survival rates are only 66%. In Africa, it's much worse. It's only 49%. So why this gap? This gap is primarily because the treatment, the time at which people reach the doctors for treatment is very much delayed. So people reach the doctor for treatment only by the time they have reached the third or fourth stage of cancer, when not only is the treatment difficult and causes considerable difficulty to the individual, but even the treatment costs are much higher. Why is it that in the developed countries like the United States, for example, they have been able to have greater success? Now, the reason for that is very simple. that there is a requirement that women of a certain age undergo screening. Every year, they do mammography. The mammograms are scrutinized every year, so they are able to catch the disease earlier. Similarly, under prevention, they are also imparted the art of doing self-examination, so that if there is any suspected developments in the body, they are able to reach to the doctors. Now let us look at what is the condition in India. In India, while screening facilities are available, and particularly so in Kerala, where from yesterday's talk I gathered right to the grassroots level, such facilities are being made available by coordination between government and cancer centers and NGOs. These facilities are available. And yet, instead of the ambitious 99% that we want to cover, only 1% of coverage is available. Now we have to look at why is that happening. The reasons are very simple. First of all, for women in India do not understand the value of preventive health checks. This includes even people like me, educated people, uneducated people. Nobody understands the importance of preventive health checks. That habit itself needs to change. And as we know, habits are very hard to build. The second reason is we like to postpone all inevitable bad news. So we try to put it off as far as possible, which is a very dangerous trend as far as cancer is concerned. Third thing, even if we know there is a possibility of cancer, we avoid it because of the stigma involved. We don't want anybody to know. Fourthly, if there is a financial difficulty, a family in financial difficulties, they will like to postpone the inevitable, particularly the women. They will care for everyone else, but I don't think anybody else pays that much attention to their health. And as a result, by the time comes to notice, it's too late. And most and mostly what happens is that by the time the matter reaches the doctor, it is too late. And the loss that the family, the community, and the country suffers is substantial. If proper awareness is given about the possibilities of a cure at much lesser cost, both in monetary terms as well as in terms of emotional and other burdens, then surely in an educated state, particularly in Kerala, we should be able to make that difference. And that is the significance of this month of October, when these webinars and other awareness initiatives are taken up. So, of course, there are new challenges that come up every year. For example, I just read yesterday that in Trivandrum, while in other developed countries, cancer is normally detected around the age of 50 or thereabouts. 35% of the cases that that were noted in Trivandrum was were cases where the age of the victim was less than 50 years, which means the screening has to start much earlier. And therefore, the challenge becomes even more difficult. Today, we are going to hear more from the technical experts about the nuances of these issues. And I therefore take this opportunity to wish all the sponsors all the very best in this great initiative that they take up every year. And I only hope that each one of us, I think we should take a pledge that all of us who have participated in this seminar, we should make it an objective to bring members of our own family, our friends' circles, and also people in our WhatsApp groups and other social media chat platforms, bring them all to at least to the level of taking a preventive health check through a mammogram every year, so that the screening becomes better and we can tackle the problem at the very beginning and therefore eliminate the possibility of a preventable death. I wish this program all success. Thank you.
Thank you very much, ma'am. I hope Madhupal sir has joined. Hello, sir. Are you there? Sir, are you there? Can you hear me?
Server's here, but I think just dropped off. He'll join soon. So let's continue.
Okay. Oh, he left?
Might be the network issue.
Okay. So can we start with the speakers? I mean, Dr. Shari Abraham? Can we start with them?
Yes.
Yes, ma'am.
So I welcome Dr. Shari Abraham. He's a consultant medical oncologist, Anandaburi Hospitals and Research Institute, Jubilee Memorial Hospital. I welcome him.
Thank you, ma'am. Thank you for the introduction. Respected Chief Guest, Madhupal sir, Shoba Koshy ma'am, respected Chairperson, PG Jayaprakash sir, and dear colleagues, a very good evening to all. Today is the 10th day of our Pink Month webinar series, and today's topic is screening guidelines for high-risk women. So I shall share my presentation. Is my slides visible? Okay. So screening guidelines for high-risk population. So over these days, we have seen a lot of topics about the screening modalities, what are the symptoms of breast cancer, what are the risk factors. So today we are going to see about screening guidelines for high-risk population. So a few words about cancer screening. We all know what screening is. Normally, a patient comes with symptoms of cancer to our clinics. So we will evaluate for the symptoms and will eventually diagnose malignancy. So that is the common scenario which we come across. So in screening, we are detecting a diagnosis of cancer before the onset of symptoms. That is, looking for cancer before a person has any symptoms. So it has a lot of advantages. We can detect the cancer early. We can have a good cure rate. Detect the by early detection in early stages, we can improve the cure rate, decrease the mortality, and eventually improve the survival. So that is about cancer screening. So coming to our breast cancer screening. So it is performed in women without any signs or symptoms of the disease so that it can be detected as early as possible. It is a form of secondary prevention. It allows early treatment and will reduce the mortality and morbidity and will eventually increase the survival rates. So in asymptomatic women, if the physical examination is negative, the next decision point is based on risk stratification. So in which risk the women comes. So it is stratified into two basic categories for the risk of purpose of screening. That is average risk and high risk. So most of our population comes under the average risk. So that the screening guidelines for average risk we already have seen in the previous classes. That is, we choose to start annual breast screening mammography at the age of 40 years and at least by the age of 44 years every year. So till 55 years, after 55 years, we can switch to every 2 years or we can continue once a year till 74 years. So that is the screening guidelines for average risk population. So who are the high risk population? Coming to the second category. So this is our topic of interest today. So for assessing risk, there are different risk assessment models like the Gale model, Claus model, BR-Capra model, Tyre-Krusik model, Bodesia model. So there are different models which have been developed that most of them have common assessment elements. Mostly it is related to age, that is age of the person, age at menarche, age at first live birth, the breast biopsies, the reports of breast biopsies, and the family history, that is first degree relatives or secondary degree relatives having breast cancer. So based on many factors, we have risk assessment models. And then how to assess the risk, that is whether the patient comes under average risk or high risk. How do we assess? So the first step is assess family history. For assessing family history, we have different tools. We can either use the US Preventive Task Force guidelines or NCCN approach. Can ask about personal or family history of BRCA related cancer or ancestry. If present, use a brief familial risk assessments tool. That is a 7-question family history screening tool. So if the family history screening is positive, using either of the USPTF or the NCCN tool, then we have to refer patient to a genetic counsel or someone who is specialized in medical genetics. So patient found and a genetic testing should be done, and patients found to have high-risk genetic mutation should proceed directly to high-risk screening protocol. That is, patients who are found to have high-risk genetic mutations will be categorized under high risk and will follow the high-risk screening protocol. And further, we'll refer to discuss the risk reduction medications and surgical prophylaxis. So if the family history screen is negative, and if the genetic testing is negative, we'll continue to step 2. In step 2, we assess the personal history, that is demographics, age and ethnicity, hormonal factors, age at menarche, menopause, age at first live birth, nulliparity, exogenous hormone use, obesity, and radiographic breast density. And in other factors, like if there is a previous breast biopsy with atypical ductal hyperplasia or lobular carcinoma in situ, or if the patient have a history of chest radiation, exposure to chest radiation between the age of 10 to 30. In these last two categories, the patient will again directly go to the high-risk population, high-risk screening population. And the next step is choose a risk prediction model, which I have already mentioned. There are a few risk prediction models like the Gale model, BCSC tool, or the Tyre-Krusik model. And based on that, we will interpret the risk. And the patient will be categorized into more average risk or high risk. So who are the high risk population for screening? There are six populations which have been described as having high risk. That is, women with a prior history of breast cancer, and women more than or equal to 35 years of age with a 5-year risk of invasive breast cancer, and more than 1.7% as per the Gale model. Next is third one is women who have a lifetime risk more than 20% based on the history of lobular carcinoma in situ, LCAs, or with history of atypical ductal hyperplasia or atypical lobular hyperplasia. So women with either of these 3 histologies with a lifetime risk more than 20%. Okay. And fourth one is women who have a lifetime risk more than 20% defined by models, which I have already mentioned, which depending on the family history. And the fifth one is women between the ages 10 and 30 years with prior exposure to thoracic artery. And the last category is women with a pedigree suggestive of or having a non-genetic predisposition, that is having hereditary breast cancer associated with many predisposing genes. So hereditary breast cancer comprises only about 5% of breast cancers. It's actually very rare. So many genes and syndromes are associated with breast cancer risk. So most commonly, we see the BRCA1 and BRCA mutations, which is associated with the hereditary breast ovarian cancer syndrome, which have approximately 10 to 20 times risk of breast cancer. And next is the P53 mutations, well-known Leigh-Fromeny syndrome, where the risk is 2 to 6 times. P10 mutation in Cowden syndrome, where the risk is 2 to 4 times. STK11 mutation in Peutz-Jeghers syndrome, where the risk is 10 to 15 times. ATM gene mutation in ataxia telangiectasia, where the risk is 3 to 4 times. And other genes like CHEK2, BRIP1, PALB2, where the risk is around 2 times. So these are the hereditary breast cancer syndromes which are associated with increased risk. So what are the screening considerations of high risk? We have already talked about the average risk population, what we are doing for screening in the average risk. So in the high risk population, the basic difference is we are incorporating mammogram into the screening strategies. So in the average risk, we are using mammogram, MRI, annual MRI into the screening strategy. For average risk, we usually use mammogram. So for high risk, we are incorporating MRI into the screening strategy. So women with a non-genetic predisposition, that is with hereditary breast cancer associated with many genes which I have already mentioned, we should start breast awareness at the age of 18 years. Breast awareness means awareness of one's own breast and the feel of one's own breast. That is known as breast awareness. It's not a systematic tool like the breast self-examination. Okay. So breast awareness is developed through breast self-examination. That's the importance. And second one is annual clinical and self-breast examination starting at the age of 25. So we are starting early because these patients having these genetic mutations associated with hereditary breast cancer are at risk of having breast cancer at an early age. So we are starting screening at an early age, at the age of 25 years. And we are doing both mammography and MRI at the age from the age of 25 years. So you can ideal recommendations to do both MRI and mammography. So we can sandwich this, like 1 year we can do an MRI, next year we can do a mammogram, or we can do in a staggered manner, like once in 6 months, we can do it alternatively. And the next one is for those women aged 35 to 40 years, a risk reduction surgeries are there, like bilateral salpingectomy oophorectomy with possible short-term hormone replacement therapy can also be advised in order to reduce the risk of ovarian cancer. So that is about screening consideration in those with hereditary mutations. And the next category is for women aged 35 years of older with a 5-year risk more than 1.7% and patients with lobular carcinoma in situ. These are also considered high risk. Here, there is no role for MRI. We consider clinical breast examination every 6 to 12 months and annual mammography along with breast awareness is encouraged. Once the woman is categorized into this category, high risk subcategory. The next one is for a woman with more than 20% lifetime risk of breast cancer based on family history. Here, the MRI has a role. And we start with breast awareness beginning at the age of 30 years, clinical breast examination every 6 to 12 months, annual mammography, which should begin 10 years prior to the youngest family member with breast cancer, but not prior to the age of 30 years, whichever comes early. And we have to refer these patients to a genetic counselor. Annual breast MRI begin 10 years prior to the youngest family member breast cancer, but not prior to the age 25. So in this category, we are incorporating breast MRI along with mammography. The previous category was those with genetic mutations. And next is if the patient has received thoracic RT between the ages 10 to 30 years for any reason, say for example, for Hodgkin's lymphoma, if she's receiving radiation to the chest wall between this age group. So these are, in this category, we have two subcategories, current age less than 25 years. In those, we begin screening 8 years after radiation therapy. That is, studies have found that the risk of breast cancer increases after 8 years. 8 years after exposure to RT. So we'll begin screening 8 years after RT with clinical breast examination 6 to 12 months and breast cancer awareness. For age more than 25 years, we do annual screening mammogram starting 8 years after radiation therapy or after 25 years, whichever is later. An annual MRI is also done 8 years after radiation therapy or after 25 years. So these are the screening guidelines in high-risk population. So we have incorporated MRI in certain populations like those who have received RT to chest wall those who have a risk more than 20% based on the family history models. And the third one is those having genetic mutations. So these are the three categories where we have incorporated annual MRI along with mammography. So these are the breast cancer screening options. This we have already heard in the previous classes. I suppose breast self-examination, clinical breast examination, mammogram, ultrasound, magnetic resonance imaging. So this is breast self-examination. We should examine the breast in front of a mirror, the hands by the side and also hands in the upright position. You have to examine both the breast and axilla of both sides, and you have to see the nipple areolar complex, whether there are any changes in that or there are any discharges in nipple areolar complex. So this is a video it's a good video which I got regarding the breast self-examination. I'll just play that. So you have to do it monthly. Ideally, it should be done after your menstrual periods and should be done on a fixed day after menopause. Should be done on monthly basis, ideally after your periods. So before taking a bath, you have to check yourself in front of a mirror. You have to see the changes in breast shape while your hands on the side and also by raising above your shoulders. You have to look for the changes in shape, differences in size of the breast. Always you have to compare both sides. Any puckering is there or dimpling or any sores, which may develop once we raise our hands above our shoulder. You have to check your nipple areolar complex for any bloody discharge. And during bathing, you have to feel your breast on both sides. So while in the standing position, while bathing, we can palpate our upper portion of the breast more, more carefully. And usually breast cancers tend to develop in the upper outer portion. But you have to completely palpate all the corners of the breast. You can apply soap for a smoother glide. You have to use your 3 fingers for palpation, as shown in this video. You have to palpate every quadrant as a breast as a whole, including every quadrant. Should not miss any part of the breast. And also, you have to palpate the axilla, both axilla, to look for any swellings. And the next position is you have to lie on your back after your bath, because on the lying down position we can palpate the lower part of the breast more carefully than the upper part. So while standing, we can't not able to palpate the lower part of the breast completely. So during lying down position, we can palpate the lower part of the breast. So as shown in this video, you can raise the right arm and keep it behind our head, and you can palpate the right breast with the help of your left fingers and also the right axilla. And you can do the same thing on the opposite side. To palpate every quadrant of the breast and axilla. A monthly self-check can help you notice a small breast change If you find any lumps, you have to see a specialist. So next modality is clinical breast examination, that is examination by a doctor. Next is mammogram. We already know this. Mammogram is nothing but an X-ray of your breast. We have different views for screening and for diagnosis. Breast is compressed in this X-ray machine, and X-ray sources pass through that. The exposure is very less, at around 0.1 centigrade the exposure by a mammogram. So it's not at all a dangerous thing. It's very effective in screening. Next is breast ultrasound. We can do this. It's not very sensitive, but if there is any contraindications for mammogram and or MRI, we can consider breast ultrasound. And breast MRI is not a recommended tool for women who are at average risk. We are using mammogram only. Annual mammograms plus breast MRI screening are recommended for high-risk women, which I have already mentioned. So this is recommended for non-BRCA1 or BRCA mutations, or having a first-degree relative with a BRCA1 or 2 mutation and have not had genetic testing themselves. Also for population who have a lifetime risk of breast cancer of 20 to 25% or greater, according to the risk assessment tools, or those who have prior RT to chest wall between 10 to 30 years, or have a genetic disease like Leigh-Ferroni syndrome, Cowden syndrome, or one of those syndromes in first-degree relatives. So these are the indications for MRI screening. So the takeaway messages: around 10% of breast cancer is familial and 5% is associated with a genetic predisposition. Risk stratification is important for deciding upon screening strategy. MRI is more sensitive than mammogram and is recommended in certain high-risk population and those with dense breast. Involvement of a clinical geneticist or genetic counselor is crucial in those having a significant family history. Thank you.
Thank you very much, sir. It was a very informative talk. Madhupal sir is also here now. So I welcome you, sir. Actually, he's a very valuable patron of our Swasthi Foundation. He's also a versatile actor, writer, and a poet. We are very much honored to have him today with us. Sir, a few words, sir.
Sharon has to stop sharing.
Can you hear me, sir?
Sharon, can you stop sharing your PPT?
Yes. Madhupal sir, can you hear us? Hello? Can you hear me, sir? Mute you. Hello, we can start with the next speaker, Dr. Deepa Rajmohan, consultant and head of Department of Radiology, Aster MIMS, Kannur. I welcome you, ma'am.
Thank you. Hope I'm audible. I'm audible, right?
Yeah, you are.
Yes, yes.
Yeah, you're audible.
Yes, thank you. Namaskaram. I'm Dr. Deepa Rajmohan. First of all, thank you, Dr. Sherry, for the very comprehensive talk about high-risk screening. And indeed, it is a privilege for me to be a part of this very socially relevant program in relation to Pink October. And really appreciate and extend all my heartful wishes to all organizers. So I'm a radiologist and I see a lot of breast scans and mammograms every day. So there is a question that we often encounter, especially while talking to patients who come for routine health checkups. ഡോക്ടർ എൻ്റെ കുടുംബത്തിൽ ആർക്കും ക്യാൻസറോ അതുപോലുള്ള ഒരു അസുഖങ്ങളോ ഇല്ല. അപ്പൊ പിന്നെ നമുക്ക് ഈ മാമോഗ്രാം ഒഴിവാക്കിക്കൂടെ? Nobody in my family has ever had cancer. So should I still undergo a screening mammogram? So this today is my task to break this age-old, potentially dangerous myth that cancer screening is only for women who have a family history of breast cancer. This is absolutely not right. So let me present to you a few hard facts. One, about 85 to 90% of the breast cancers occur sporadically. It is sporadic in nature. By sporadic, in simplest words, it means without one pointable cause. Out of the blue, without a particular cause. Putting it in other words, only about 10 to 15% of the breast cancers, women with breast cancers, have a positive family history. So just think of the number 90%, 85 to 90%. If you take 10 females who are detected to have breast cancer and talk to them, ask them about it. So 9 out of them wouldn't have had anyone in their family with a history of cancer. So that is the hard fact. So last day I was listening to a famous oncosurgeon in US. Sorry, I can't recollect her name. So she was asked, "Ma'am, what are the major risk factors for breast cancer?" And she said, there are two biggest risk factors. One is being a female, and two is getting older. So that is scary, but you have to be well aware of this. Most of the breast cancers we see are seen between the age of 40 to 50, and it progressively increases as you get older. So that is why most of the cancer screening programs primarily focuses on age as a factor and nothing else like family history. Uh, what is the screening basically? It focuses on picking a cancer at a very early stage. Why? Because earlier it is picked, the smaller the cancer is, it is easier to treat. So it saves you a lot of worries and morbidities. That is what we say in medical terms in the future if you pick it really early. So the action plan is very simple, a simple X-ray technique, that is mammogram. I'm sure what is a mammogram and how is the screening done, everything has been elaborated in the previous day's sessions, but it is like a mammography is an X-ray technique. It is a simple X-ray, 3 or 4 X-rays which are taken. You should make sure that you start getting screened at the age of 40 and follow up with an yearly mammogram, yearly or as and how your doctor prescribes it for you. So, അപ്പോൾ ഒരു മറുചോദ്യം വരാം ലൈക്ക് ഫാമിലി ഹിസ്റ്ററിക്ക് അപ്പോൾ ഒരു റിലവൻസോ സിഗ്നിഫിക്കൻസോ ഇല്ലേ? തീർച്ചയായിട്ടും ഉണ്ട്. That is what Dr. Sherry has been elaborating. So, in short, if you have a family history, like നിങ്ങളുടെ അമ്മയ്ക്കോ സഹോദരിക്കോ അല്ലെങ്കിൽ even if your aunt has had an history of breast cancer or even a related gynecological malignancies like CA ovary, especially if they have had it at a relatively younger age group, then you belong to a higher risk group. Okay. You might have to start screening at an earlier age, and it need not be mammogram always. It could be an ultrasound or even an MRI breast, depending on the density of your breast. So Dr. Sherry has detailed about it. So I'm not going into the details, but what you should do, അങ്ങനെ എന്തെങ്കിലും ഒരു issues നിങ്ങളുടെ ഫാമിലിയിൽ cancer history ഉണ്ടെങ്കിൽ you should go meet your doctor, share your concerns, give all the relevant histories, and he or she will make a tailored, personalized screening program for you and just make sure you adhere to it. So I'm not stretching it any longer. So take home messages. Breast cancer screening is only for those women with a family history എന്നുള്ളത് ഒരു age-old myth ആണ്, which is absolutely not right. So get this myth out of your head. So cancer screening is just an act of love and responsibility towards yourself. So this October, let us pledge that we protect ourselves. So get yourself screened, spread the word among your friends and family, and stay safe. Thank you.
Thank you, ma'am. Thank you very much. Sir, Madhupal, sir, are you ready to speak now, sir? Sir? Madhupal, sir, are you ready to speak now? Madhupal, sir? Sir, are you there?
Not there.
Hello.
The
Yes, ma'am.
Jayaprakash sir.
Jayaprakash can talk, I think.
Hello.
Yes, sir, you're audible.
Yes, sir.
A very good evening to all of you. And first of all, I thank Dr. Ansar and the organizers of IRIA, AMMA, and Swasthi Foundation for giving me this opportunity. ഒരു മാസം നീണ്ടു നിന്ന ഈ ബ്രസ്റ്റ് ക്യാൻസർ സ്ക്രീനിങ് വെബിനാറിൻ്റെ 10ാം ദിവസമായ ആണിന്ന്. ഈ ദിവസങ്ങളിൽ വിവിധ ബ്രസ്റ്റ് ഇമേജിംഗ് ടൂളുകളെ കുറിച്ചുള്ള ചർച്ചകൾ നടന്നു. By far the most significant tool is X-ray mammogram. Ultrasound of the breast has a complementary role to only, and it is never used as a sole screening tool. The two together has more than 90% accuracy rate. The sensitivity of X-ray mammo decreases with dense breast in young ladies. Hence, the preferred modality is MR mammography. MR mammo has more than 95% sensitivity, but the specificity is only 70%. This leads to a lot of false positive, leading to unnecessary biopsies, patient anxiety, and patient suffering. A combination of X-ray mammo with MR mammo is the most ideal in young ladies. The other tools like contrast enhanced ultrasound mammo, 3D mammography, or the so-called tomosynthesis are methods to enable sensitivity and specificity in evaluation of dense breast, but these are not easily available and more expensive. These are of particular use in problem solving when the X-ray mammogram or the ultrasound has not succeeded. The imaging of choice in BRCA mutated young ladies, as discussed, is MR mammogram. The reason for this is most BRCA mutated ladies are young and have very dense breast. And second is where the sensitivity of X-ray mammogram reduces. And there are always chances for multicentric disease which may be missed in a X-ray mammogram. So the combination of X-ray mammogram with MR mammogram is the choice in patients with BRCA mutated breast. It's not breast cancer, breast. I was listening to the speakers today. Both Dr. Sherry and the second speaker had an excellent disposition of the subject. Sherry has gone in depth into the risk categorization of breast cancer and the screening protocol for the high-risk breast cancer patients. Is there any question from the audience? Priya Shekhar. Hello. Audience, please. Hello.
Yes, sir. You are audible, sir.
Is there any question from the audience regarding this high-risk breast cancer patient screening protocol?
In high risk cancer patients, when will we do MR mammogram, sir?
High-risk patients, actually, it is the recommended protocol along with X-ray mammogram.
So, if it is a BRCA mutated patient, then currently we are doing 6 monthly X-ray mammogram and every 6 month X-ray and alternate with MR mammogram.
Is there a chance to miss some cancer in between?
Still, it is there, sir, because that's why we have brought down the screening time from 1 year to 6 months in BRCA mutated patients. At least one imaging in every 6 months needs to be done for patients with the BRCA mutation, non-mutation.
Why don't both done together at 1 year interval?
Sir, there are two recommendations, sir. Either we can do both annually, that is both an mammogram and a MRI annually. And second one is, as Ansar sir rightly pointed out, we can do it in a staggered way. That is, once in 6 months, we can do it alternatively, MRI and mammogram like that. Both are acceptable.
These are tumors where the doubling time is 2 to 4 months. In certain cases, it's only 2 months. So it can by 1 year that we may patient may develop an interval cancer. By the time the 1 year time period reaches, patient would have already have a malignancy. In certain cases where the doubling time is much less, is in 2 months, but most of them it will be in the around 4 months. That's why we can do a mammogram at every 6 months, an X-ray mammogram at 6 months, and 1 year we have to do an MR mammogram. So the exposure to X-ray will be annual only.
Okay, I accept that, but is it likely to lose that interval cancer in the X-ray mammogram in BRCA mutated patient?
It is possibilities there, sir. We have to do not only X-ray mammogram, we have to do ultrasound screening also in such patients.
Okay.
But the other usual screening does not involve ultrasound. standard screening, only X-ray mammogram will be sufficient. But in this BRCA mutated or BRCA carriers, along with the X-ray mammogram, a detailed ultrasound also has to be done at 6 months.
In screening standard risk patients, our people are using both X-ray as well as ultrasound as a
Standard
complement.
risk is not necessary, sir. If the X-ray mammogram would be sufficient, since we are not doing, we are not doing it for entire population. That's why we have enough radiologists to do it, because the screening is now only opportunistic. But if we take the entire population of the Kerala, there won't be sufficient radiologists to do ultrasound for each and every person who require a screening. So
I agree.
X-ray will be easy to read and report.
Report, yeah. Okay. I thank both the speakers. Let us conclude. Is there any more question?
I just spoke to Madhupal sir. He's also in some other meeting. That's why he's not able to connect with us.
Okay.
So he tried in between, but then somebody else was speaking, so he left. But anyway, he said it's okay. Maybe next time.
Okay.
Then I think we can
Conclude.
conclude. Yes.
Yeah, we can conclude the meeting.